Dear colleagues, welcome to this 15-minute interview on the 5-year SURTAVI data. My name is Nicolas Van Mieghem from the Erasmus University Medical Center, and I will discuss the results of SURTAVI and put them in perspective to the updated ESC guidelines together with two distinguished colleagues. Dr. Nicole Karam from Paris, an interventional cardiologist, and Dr. Thomas Modine from Bordeaux, a cardiothoracic surgeon. So let's first highlight the results of the 5-year SURTAVI data. SURTAVI was a randomized trial enrolling more than 1,700 patients at intermediate operative risk to either TAVI with a supraannular self-expanding early generation device. 84% of the patients received a core valve, 16% received an Evolut R, or surgery with a bioprosthesis. The mean age of the patients was approximately 80 years old. The STS score was 4.5. 50% of the patients also had some kind of frailty on board based on a 5-meter gait speed. Let's go to the results. The primary endpoint was a composite of all-cause mortality and disabling stroke. There was no difference whatsoever at 5 years between the two treatment strategies. If we then look at other endpoints, for instance, aortic valve or heart failure-related hospitalizations, no difference between the two treatment arms. There was also a low rate of valve thrombosis and valve endocarditis. It was 1% or less for both treatment arms. There was only an excess of re-interventions in the TAVI arm as compared to surgery. But if we dive into the data and do a landmark analysis between 2 and 5 years, there was no longer a difference between the two treatment strategies. So basically, the difference was entirely driven by an increment in re-interventions early after the TAVI procedure because of paravalvular leakage issues. And we'll get to that later on. But it was very much notable that between 2 and 5 years, only 6 patients after TAVI and 7 patients after surgery required a valve re-intervention. And then in terms of valve performance, the aortic valve area was larger after TAVI, the mean gradient was lower, but paravalvular leak occurred more often after TAVI than with surgery. So those are the highlights of the 5-year SURTAVI data. Nicole, how would you put these data then in perspective of the updated ESC guidelines?
Well, in my opinion, those data are totally reinforced current guidelines. I mean, if we go through current ESC guidelines that we got this summer, we basically see that TAVI is recommended for any patient who is above 75 years old, almost any patient, regardless of the risk. And if we go to patients who are younger than 75, then here we have to go through the risk and decide whether it's TAVR or SAVR. So we could have wondered whether this was not too courageous, let's say. But given the results of SURTAVI, we can be sure today that our patients are safe with going to TAVI this quickly, even if they have a low risk. So I guess it totally reinforces the messages of the guidelines.
I completely follow your reasoning, because at the end of the day, the guidelines were put forward without longer term data, because all the data were predominantly around 2 years. And what is also of interest in SURTAVI is basically the largest trial with the most patients who reached the 5-year endpoint, who were still alive at 5 years. So the mortality there was 30%, and that is as expected, I think, for 80-year-old patients with comorbidities. But with other randomized trials, mortality at 5 years was close to 50% or beyond. So I think that is an important additional information from SURTAVI. So Thomas, you as a surgeon, based on the SURTAVI data, based on these updated ESC guidelines, who would you refer then at lower risk to TAVI, and who would you then refer for surgery?
I mean, I'm quite aligned with the findings. I mean, the recommendations of the guidelines, because we are accumulating a lot of evidences now, and as you have said, we have now a larger study with more than 700 patients in each arm with the follow-up above 90%, despite the withdrawals of some patients, which are equivalent in both arms. This is really very important. I think we still, despite that, we have to look at every case patient by patient. And I think in some indications, we should be able to discuss if it's better for SAVR or it's better for TAVR, based on some anatomical recommendations, mainly to avoid the pitfalls that we know already that could have led to some re-interventions, as you have said. But basically 75 and above, it's our current practice to go for TAVR. Below, still consider discussing, and in between, we see.
Can you briefly comment on some anatomical criteria that you would favor for TAVI, for instance, and others that you would favor for surgery?
Yeah, I mean, first, small annuli is definitely favorable for TAVR. I mean, you cannot, doing an enlargement of the annulus for a surgical enlargement is not an easy affair. And I can tell you all surgeons cannot do it. And if you enlarge to implant the 21 instead of 19, it's not enough. You have to be able to implant the 23 or 25 to be able to receive TAVR in the valve and valve later on. So this is one. Small annuli equal TAVR or in favor of for TAVR. In large ones, the discussion is based on what is the risk of paravalvular leak, actually. All the anatomy that favors the presence of paravalvular leak, I would definitely push to do it more surgically. If we are able to achieve optimal implant, TAVR is definitely the gold standard today. We have to admit it.
Yeah, so there was also data on the hemodynamic valve performance. We talked about gradients, we talked about paravalvular leaks. Nicole, what is your take on that? Because we have to consider, of course, that we were studying early generation self-expanding supraannular functioning valves.
Yeah, that's exactly the comments that we've been thinking about. If we look at the paravalvular leak that we had in this study, we might consider that it is too high, and we might wonder if we would really want to give this kind of procedures to our younger patients. But when SURTAVI was performed, as you said, 84% of the patients had the TAVI with the first generation core valve and the remaining with an Evolut R. Today we have the Evolut Pro Plus device, and we have the possibility to recapture the device. We have a better sealing, we have the external wrap around it. So the rate of paravalvular leak, we can expect it, and we do see it in our daily practice. It is really reduced compared to what we have in SURTAVI. So that's why this rate of paravalvular leak is not really an issue in my point of view. We also gained experience. We also have different techniques for implanting the valve. And I guess with all of that, we can be sure that the questions that we had on paravalvular leak will subside with time.
Mm-hmm. And what about the hemodynamics of the valves, Thomas? Obviously, the gradients were lower after TAVI, the valve area was larger. There was more patient prosthesis mismatch and severe patient prosthesis mismatch with surgery. Is that clinically relevant in your opinion?
Yeah, I mean, just allow me just to jump to what Nicole has been saying. So now you have a new platform of a supraannular Evolut Pro Plus device where a paravalvular leak is almost not an issue at all if you make a careful analysis of the anatomy and choose the right size. You add to this the new implant technique, cusp overlap, commercial alignment, which preserve, I would say, the options for the future and reduce mainly the risk of pacemaker, which is really very important. We don't talk much about it. And then you add the feature of supraannular, better effective orifice area, and less gradients, which of course has an impact. I mean, we have seen it now for ages. We know this from the surgical literature. If there's anything to learn from there, is that higher gradients could lead, I mean, severe mismatch is definitely not a good thing. We should avoid it. And for that particular reason, this supraannular platform is definitely superior and offers a great guarantee of durability. Mm-hmm. So it matters. I agree.
Yeah. Okay, so the mean age of the patients was 80 years old. The guidelines talk about 75 years old. Is this the end of the story with SURTAVI 5 years, Nicole, or do we need more data from the low risk? Do we need prolonged follow-ups? What is your take on that?
Well, I guess we do need both, because today we got to the 75 years cutoff in the guidelines, but I'm not really sure that this is the cutoff we're going to be working with in 10 years. But it's too early maybe today to just say, okay, let's drop the age to 60, let's drop it to 50, 55. It's too early. We really need more data, whether on the long term, whether on the low profile. It's encouraging, but we need to stay modest on the results overall.
And I totally agree with that, because we are all aware of the degeneration process at a younger age that is different from the degeneration at an older age, right? So bioprostheses tend to degenerate faster and more aggressively at the younger age. Would you agree with that, Thomas?
Yeah, I mean, I cannot disagree with you at all, Nicola, anyway, and Nicole have said it very clearly. I mean, you don't want to put on the table to do a sternotomy or even minimally invasive surgery, a patient who is 85, that you didn't want to do, where you could have done it at 75. You know, the risk is not the same. Mm-hmm. And also, you don't want to end up doing an aortic valve replacement plus a root replacement, where you could have done it only by doing an AVR, putting a big valve, and then keep the door open for valve in valve. So my take on this, I mean, is we have really to maintain the quality of a hot team discussion, and honestly put all the eggs in the basket and then discuss what is best for the patient. I mean, again, what we have today is that we have a platform of supraannular valve which is offering fantastic results. We have seen it. We have a good follow-up. So this is no subject to discussion anymore. However, I think where we still have some gray zones, we have to keep the door open, being very humble, and discuss the extension of indications very carefully. I agree.
Yeah, so I think the three of us agree on how to interpret the data. But if we have a younger patient in our outpatient clinic who needs a valve replacement, the decision, is it a shared decision-making process now in Paris and in Bordeaux, or is it still the heart team of physicians that just takes the call? How is that with you, Nicole?
Oh, today it's very difficult to say that I'm going to take the decision in my or all alone. We have a heart valve unit. We do discuss between cardiac surgeons and cardiologists, but it's very difficult, and we don't need to take any decision without including the patient. Mm-hmm. So today we have to listen to the patients, even in the guidelines, to include the patient's voice. But but we need to make sure that we really give the patient the good information and really the balance, how to choose. So he needs to know what's good, what's bad, what are the results of each technique. And in my center, what we do sometimes is to have a combined consultation at the same time with the surgeon and the interventional cardiologist, in order to make sure that the patient really knows what he's choosing and why he's choosing it. But of course, in case both techniques are feasible and both techniques have the same risk, of course.
Thomas, how is it with you?
You know, in Bordeaux, we have really very effective heart team. But I mean, let's be honest, Nico, there is no patients anymore who comes to say, no, I don't want a TAVI, I want a surgery. So they all come and they want a TAVR. So what's going to be difficult today is to convince them that sometimes surgery could be better than TAVR. This is the question. And I think the only way to do it is having a good cardiologist. I mean, they are all good. What I wanted to say by this is someone reasonable who say, yeah, I really believe that we may not achieve a good implant and you better go for surgery, although it's a bit more invasive, although there's it needs long-term, I mean, more time to recover from it. But I mean, the question is already answered, Nico.
Yeah, I think you're right. And I think we're talking about two complementary strategies. And in some patients, surgery will be the better option. In other patients, TAVI will be. And I think SURTAVI with the 5-year data really provide us with compelling evidence and a scientific background to at least promote TAVI in patients 80 years old and beyond, and to reassure those patients that they will get a good treatment. And at the same time, I think it opens also the door to lower risk patients. With that, I would like to thank Nicole and also Thomas for their great insights. I would also like to thank you to participate in this interview. Stay well.